So I had a lot of feedback regarding topics, and one of the topics was ATLS. So obviously, we are unable to cover everything, but this was one of the things was if I can outline the plan of the session. This is the plan of the session. It's really very ambitious, really ambitious. ATLS, osteoarthritis, common orthopedic conditions of upper limb and lower limb, really. Limping child, bone pain, structure, metabolism, muscular dystrophy, bone tumors, gout, septic arthritis, pseudogout, and consenting. So I think what we'll do is we'll at least try and cover some bits. I reckon we will reach up to the limping child, and then we will call it a day, and then we can do another session depending on how it goes, okay? So if you're all ready, we will begin with our first question of this evening, which is this, not the other one. Which should be assessed first in a trauma patient? You can't mark, unfortunately, obviously, but I guess you all probably know the answer. If you have ticked airway, you are thinking in the right direction. We will come to that in a minute. So the right answer is airway. Question 2. A patient is found unconscious after a fire in his bedroom. He's found to have severe burns around his face. What is the first aspect of treatment? Tetanus, cover the wound, airway, obtain blood work. What do you think? I think what you think is right. Yep, airway. Next question. What is the next step in assessment of a traumatic patient after airway is established? Neurologic, circulation, breathing, airway. Someone is breathing now. Someone's got patent airway. What do you want to check next? The right answer is breathing. Which injury is most common in rear-end motor vehicle accidents? What do you think? Cervical fractures? Not really. I see a lot of these every day. And forearm fractures? Not really. Rotational neck injuries? Not really. Hyperextension, hyperflexion neck injuries, also called whiplash. Whiplash, that's very common. Okay, so that's the right answer. What's the first priority in treatment of an unconscious patient? Checking blood pressure is really important. Establishing IV access, absolutely important. Checking the pulse is really important, but establishing an airway is your first priority, okay? So let me go back one step. So what you've seen is that I'm trying to, I know I'm not insulting your intelligence. I'm keeping it very, very simple, just to drum it into you very, very clearly that your first priority is A, which is airway. Your second priority is B, which is breathing. Your third priority is C, which is circulation. Your fourth priority is D, for disability or neurologic condition. And your final priority is E, environment and exposure. So you expose the patient. And we'll come to that maybe, but let me take you to this triage scenario, which is quite interesting. I want you to spend a couple of minutes reading this. This example really gives you the basic message of the ATLS principle. And if you can get this scenario right in your head, you will then understand what ATLS is all about. We obviously can't cover all ATLS today. Okay, this is just a taster of ATLS. So have a read of this. So, so this is a triage scenario. In a shopping mall, 6 people have been injured in mass shooting. Okay, and these are 6 patients. Essentially, patient 1, a young male is screaming, "Please help me, my leg is killing me." Another patient, young female, has cyanosis and tachypnea and is breathing noisily. Third patient is an older male lying in a pool of blood with his left pant leg soaked in blood. Next patient, a young male lying face down and not moving. Next patient is a young male swearing and shouting that someone should help him or else he will call his lawyer. And finally, a teenage girl is lying on the ground crying and holding her abdomen. So let's go patient by patient. Patient A, young male is screaming, "Please help me, my leg is killing me." What does that tell you? That tells you that his airway is patent. His breathing is okay. His circulation it should be reasonable because he's not in shock. So his problem is pain right now. So he shouldn't be your priority. Okay, so you park him. Patient B, young female has cyanosis and tachypnea, is breathing noisily. So cyanosis is when you do not get enough oxygen to the skin and the color changes. Tachypnea is fast breathing and noisy, which means there might be some airway obstruction. So clearly, you can't even reach C here. This patient B, has a problem with A, airway, and B, breathing both. So this patient is your priority. Keep that in mind. Patient C, older male lying in pool of blood with his left pant leg soaked in blood. So then they don't give us much information, but the indication is that probably the isolated injury is the left leg fracture. And there's a soak of, there's a lot of blood there. So probably his airway breathing is okay, but his circulation is the problem. So the problem here is C, circulation. D, interesting, a young male is lying face down and not moving. You could interpret this anyway. What I would say is that because there's not much information, this patient potentially has an airway problem, possibly a breathing problem. He's not moving. There could be a circulation problem. He could be in shock. He could be in coma. Okay. E, young male is swearing and shouting that someone should help him or he will call his lawyer. Now, this guy obviously is absolutely fit and well. Okay, he probably is just in a little bit of pain. So he's your last priority. To be honest, you don't even want to see him probably. So last patient is teenage girl lying on the ground crying and holding her abdomen. Okay, so she is probably got abdominal pain, but could she have a pelvic fracture? Don't know, potential. But looking at this risk, these patients, your priority would be patient D and patient B. So I would go to patient D first, but I would not blame you if you went to patient B first. Okay, so you won't be wrong. So in my order of clinical priority triage here would be patient D first, young male lying face down, not moving because his problem is airway. Patient B, because her problem, again, young female, cyanosis, tachypnea, is A and B potentially. And then I would probably go to patient C, who has a circulation problem because he's in a pool of blood. He must have open fracture. And that's why there's a lot of blood which has come out of his leg. Okay, so that is my third priority. My fourth priority, once again, would be one of the two, A or F. But, you know, I would probably go to the teenage girl lying on the ground crying and holding her abdomen because she might have had something in there, but her airway, breathing and circulation seems to be okay. And immediately after that will be patient A, young male screaming, "Please help me, my leg is killing me." This guy could have a limb-threatening problem or pain or just a fracture. So it's not life-threatening, okay? And then lastly, if you have time, you would probably go to the man who's going to contact his lawyer, okay? So this triage tells you, this hones in the entire scenario of the ATLS principles, okay? So this is in brief, this is ATLS for you, okay? A, B, C, D, E, as we discussed, airway maintenance. And in A, you don't only just maintain the airway, you also hold the neck immobilize the neck so that you maintain cervical spine immobilization. Okay, so that is A. B is breathing and ventilation. C is circulation. D is stability, and E is exposure. And this should not take you more than 10 seconds. 10 seconds. Someone is on the floor. Hello, sir. Hello, ma'am. How are you? What's your name? What happened? And if they can say, hello, my name is Mary Smith, and there was a shooting here, you know she's out of the woods, okay? You don't want to then look at her. Go to other one. You have done the ABC quickly, all right? So this is your 10-second ABC. If someone can speak, if they can't speak, you look at them, okay? If they're breathing, you know the airway is clear, their chest is going up and down, you know there's breathing, you then go quickly to circulation. But you've got to establish A before you move on to B, whatever it might be. Okay, A, B, C, D, strictly in that order. So, and that's a bit about ATLS, to be honest. I'm not going to go into more ATLS scenarios on this. We can have another full session on ATLS a bit later. Let me come to this chap, completely opposite from ATLS. This is an elective setting, okay? Some of the examples I'm going to use are to give you a message about what is common, what is not common, okay? So this guy, 75, long-standing right knee pain, no history of injury, walking makes pain worse, most likely diagnosis. And you can see his picture. What can you see in the picture? You can see the left leg is straight, normal. The right leg is curved. This is called the bowing of leg, okay? And this bowing of leg is clinically called a varus deformity. Sorry, okay? The varus deformity. So I'm asking you for diagnosis, but to help you, I've got an X-ray here, okay? And it shows you that he might have some loss of joint space on his right knee. So if you look at the normal X-ray of the knee here, that's your femur, that's your tibia, your fibula, that's your lateral joint space, tibial spine, medial joint space. You can see medial joint space and lateral joint space is almost similar. Here, that's your lateral joint space, medial joint space almost gone, okay? So now, what's the diagnosis? Gout, long-standing right knee pain. It's not acute, can't be gout. Pseudo-gout, once again, it's not acute, can't be that. Osteoporosis, no, it does not present like this. Rheumatoid arthritis, once again, no, because there would be other features, okay? But you can't say that, no, it can't be rheumatoid arthritis. It can be, but most likely is osteoarthritis, okay, given the picture. That's the right answer. So we've seen this X-ray. So radiological features of osteoarthritis is all of the following except joint space narrowing, subchondral sclerosis, osteophytes, subchondral cysts, and periarticular erosions. So the answer is all of them are features of osteoarthritis except periarticular erosions, which are classically seen in rheumatoid arthritis. Okay, so not in osteoarthritis. And osteoarthritis has a radiological grading. If you look at the X-rays of the knee on your screen, this is called the Kellgren-Lawrence classification, grade 1 to 4. And you don't have to remember this. This is just to explain to you that what you see in grade 4 did not happen in one day. This has probably taken best part of 10 years or maybe 5 years, okay? So it goes progresses from grade 1, 2, 3, and 4. And when you reach grade 4, you know that this is really, really bad. And this might help you in choosing your treatment options for the patient. Now, you'll also say that we always show you knees, but I want you to see some other X-rays today. So on the left of your screen is a normal looking hip X-ray, okay? So you can see the ball of the femoral head, you can see the neck, you can see the lesser trochanter, greater trochanter, you can see the proximal shaft, you can see lovely primary compression trabecular here, beautiful. That's acetabulum, okay? and then that's the ischium, and then that's going up to the iliac crest. If you look at the X-ray here, you can see there's been loss of joint space here. Can you see that? And there's early osteophyte formation here. Okay, same patient after few years. Can you see? This is worsening of the same. This, you can see some more osteophyte formation, and finally, this gets. You can start seeing some osteopenia because this guy's not walking now. He's too much pain. All the classic features: reduction in joint space, subchondral sclerosis, this whitening hair. Okay, this whitening hair is subchondral sclerosis. You can see some cysts here, which you could see here as well. So these are cysts. Where my arrow is, this arrow here, this arrow here, this arrow here, this arrow here. All these are small, tiny, tiny cysts. Sometimes they become quite big, these cysts. Okay, and that's when we have to probably fill them up with some bone graft if required. Similar thing with the knee. You can see the knee, that's your patella in the middle here. Lower end of femur, upper end of tibia, fibula, normal looking X-ray, lateral joint line, medial joint line. Look at this X-ray. You can see some reduction in joint space here. Okay, early arthritis here. Okay, look at something more advanced. Okay, this is now almost kissing each other here. This is like completely rubbing in each other there. So that is really in an advanced state. And this is where you can see it starts to open up a little bit more medially, laterally. Okay, so can you see there's subchondral sclerosis here? Cyst is quite nicely visible in this one. See, there's cyst there. Okay, cyst here, cyst here. Okay, and then you can see cyst here, lipping, this is called osteophyte formation, all the classic features. You can see something similar in the index finger. DIPJ is quite commonly arthritic. So you can see this is normal on your left screen, right screen, you can see some lipping here, reduction in joint space, complete loss of joint space, lot of osteophytes. Okay, this is last stage. So this is X-ray of not the wrist, but the carpal bones. And you can see I'm trying to concentrate on the base of the thumb. So towards the left here, this is where I want to show you. This is the base of the thumb. First carpal metacarpal joint, first CMCJ. Okay, this arthritis is very, very. Can you see a little bit of sclerosis here, and it'll advance into beak formation here. Okay, and you can see lots of cysts in this one. Can you see lots of cysts here? Complete loss of joint space. So in terms of clinical findings in OA, fairly simple. Deformity, yes or no? Yes, in advanced stages. Muscle wasting, yes, in advanced staging. Why? Because they're not walking, they're not using that part. Effusion, yes, because the synovium secretes fluid. Not always, but effusion, yes. Tenderness, yes, you will get joint line tenderness. Stiffness, obviously, because of pain and because of arthritic phenomena, which is reduction in joint space. There's not much fluid there's not much flexibility. That's why there's stiffness. Skin nodules, no. Why? Rheumatoid. Tophi, no. Why? Seen in gout. Skin changes, usually not. They are seen in psoriatic arthritis. You're right. Okay. Right. So this was a patient in your clinic with knee pain. What other information do you want from the patient? In terms of his general health, you would want to know whether they have any diabetes, respiratory problem, heart problem, history of cancer, what drugs they take, how much they can walk, what's the general health like, and everything else, because this will help you formulate a treatment plan for this patient. Do you want further imaging like CT, MRI scan, ultrasound scan? Will it help? Well, it depends what you're dealing with, okay? For an X-ray, which I showed you for the knee, you can get all the information from that X-ray to plan your treatment, so you don't. In certain cases, you do want further imaging, and I'll show you in one of the examples, okay? And then what treatment options do you have in knee arthritis or hip arthritis? You must know the risks and benefits of each treatment option, mainly conservative versus surgical. And then if the pain is, so in my opinion, the only indication for joint replacement surgery if the pain is unbearable. Remember, joint replacement is a pain relieving operation, only for pain. And that's what I tell every single patient who comes to my clinic. Look, if you cannot bear the pain you have, only then I'm going to offer you a joint replacement. If there's any other way I can reduce your pain, that's what we'll try, because joint replacement is the last option. Because there are risks in the operation, okay? So there's risk in every operation, but risk in joint replacement are more because, for example, risk of a blood clot, risk of infection. Infection in joint replacement is disaster. It's really bad news, okay? And then finally, how do you do a TKI? These must be a question. So we'll go through some of these, okay? So this was X-ray of that guy, and so he's got a knee replacement in now. So that's the femoral component on the top, tibial component in the middle. It's not empty here. It looks like, oh, what's going on here? It's plastic. It's a plastic insert which you can't see, and that's why it's radiolucent, and that's why it looks like there's a gap there. There's no gap there. Okay. So for example, it looks like a gap here between the two bones here on the X-ray. What does that mean? Is there a gap? No, there's no gap there. What's that then? That's cartilage. Okay, because you can't see cartilage on X-rays, that's why you look at the gap. Okay, so that's an example of a total hip replacement. So some of the questions, true or false, about arthritis, just to test your understanding. Most people with arthritis require surgery for treatment. True or false? Osteoarthritis is the most common type of arthritis. True or false? Arthritis is also referred to as wear and tear arthritis. True or false? Weight-bearing joints are most commonly affected. True or false? Most patients have increased joint pain during activity relieved by rest. The disease is more prevalent among older people. And osteoarthritis can be diagnosed with a simple blood test. So what are the answers? Right. Most people with osteoarthritis will require surgery. That's false. Most people will not require surgery. Most people are okay with painkillers, modification of the lifestyle. Only a few require surgery, okay? It's the most common type of arthritis indeed. It's also referred to as wear and tear arthritis indeed. Weight-bearing joints are most commonly affected, absolutely, hips and knees. And yes, the classic hallmark of the disease is increased joint pain during activity relieved by rest. And it is seen more in older people above 60. It cannot be diagnosed by a simple blood test. So whoever tells you that they have had a blood test for arthritis is probably talking about some form of rheumatoid arthritis where they have RA factor done. Having said that, even RA cannot be diagnosed by a positive RA factor, and we'll talk about that maybe today or some other day. So what is arthritis then? It is simply wear and tear of the cartilage which caps the ends of the bones in the joints. As simple as that. In the example you can see here, that white glistening cartilage, when it starts wearing off, that is called arthritis, osteoarthritis, okay? And if it's caused by infection, it's called septic arthritis. If it's called by rheumatoid immunological process, it's called rheumatoid arthritis. If it's called by a condition which affects the skin as well as the immune system, it's called psoriatic arthritis, okay? So these are different forms of arthritis. But this is a basic pathology, okay? And this example just shows you what we saw on the X-ray really. So what are the risks of arthritis? Can I ask you in this question? So the risk of arthritis are all except age. We established that, haven't we? More age, more risk. Weight, straight away. Higher the weight, higher the risk of arthritis. Gender, unfortunately, yes, in females, more common. Genetics, it has a role to play. Sometimes we see young people who are in their 30s, okay, who are not big, they are not overweight, they're fit and well, but they get arthritis. This has got to be genetics. Trauma, unfortunately, yes. If you break your bones near the joints, and if the fracture has gone through the joint, like we discussed in the last session, if you have a fracture of the elbow or wrist which has gone through the joint, you are bound to have post-traumatic arthritis. Risk of O increases in all except stock market traders. Has nothing to do with this. Okay, that was just for fun. So there you go. So these are all, once again, to revise: age, late 40 onwards, but more commonly in reality is 60 plus. Gender, female, obesity, previous joint disease or injury, and genetic factors. Okay. So how can you treat arthritis conservatively? You can try any of these. Ask them to rest it, difficult. Lifestyle modification is do not overdo things. Okay, like kneeling down if you have knee arthritis. In the garden, use pads in your knees. Okay, find ways to use instruments to help you. Painkillers, braces and splints can help a lot. Physiotherapy helps a lot. Joint injections are very helpful. Okay, and you can inject a host of things and then surgery. So what sort of joint injections can you do? So can I ask you the question? So all of the following are used in joint injections in arthritis and they help, except steroids. Yup. They are the ones which have been used for more than, I would say, 80 years now. 80 years, 70 years, yeah. 1950s was the first time it was used, so yeah, 70 years. Hyaluronic acid is an interesting one. It's quite common actually. Hyaluronic acid is a chemical which is found in the synovial fluid, and it is thought that if you inject this, it increases, it reduces the friction and increases the mobility of the joint. That's why it helps. PRP is platelet-rich plasma. I don't know if you've heard of this name, platelet-rich plasma. Have a look at this test tube. This test tube, essentially what you do is you take patient's blood, patient's blood, going back to 1,000 years ago, take the patient's blood in a test tube and then spin it at 3,000 RPM. Then after about 5 minutes, this is what you get. You get 3 layers. The red layer bottom is the red blood cell, the middle layer is the platelet-rich plasma, and then you get the plasma on the top, the yellow buff, which is the platelet-poor plasma. So you inject, and you take a syringe, put your needle there, and in the middle section, aspirate that, and then inject it into the knee. Essentially, the theory is that the platelet-rich plasma has a lot of growth factors which can help healing of the cartilage, and that will help. And that has helped arthritis, there's no doubt about it, okay? Stem cells, of course, stem cells can help, particularly in young people, but how much they can help, we don't know. There's no evidence that biphosphonates will help inside osteoarthritis anyway. So the answer here is biphosphonates, okay? In terms of surgery, what can you do for surgery? So you might have just heard, oh, someone's got arthritis, let's replace the joint. Yeah, you can do that, but there's a lot of other things you can try before doing that operation, which are through keyhole, you can wash the joint. I do that a lot, especially in young patients, because I want to buy time. Whatever happens with that debridement, I don't know. Essentially, you wash off the products of pain and they get pain relief for about 6 months or so, but they're back to square one then. So a lot of people don't like that. Open debridement I've mentioned there because this is something which some people still do who don't do arthroscopic work. Partial replacement, that is interesting. In knees, you must have seen it's usually the inside of the knee which is affected. So a lot of people have said, okay, why do we replace all knee then? Just replace a part of the knee. And this is called partial replacement or unicondylar replacement. And unicondylar replacement has been quite successful, especially if you have a young person who's about 50, 55, you replace their knee, unicondylar, that will take them for another 10 years. Then you do a total knee when they're 65, 70, okay? Osteotomy, what is osteotomy? Well, osteotomy is when you break the bone and reset it. That's called osteotomy. Osteotomy, okay? Osteo is bone, tomy is cutting it. So cutting it open. So osteotomy. So what happens essentially in osteotomy is when you cut the bone and reset it, apparently it causes decompression of the blood in that area, and that helps arthritis, and also realigns the joint, which might help arthritis. It's not a very commonly used technique, but it used to be, it is still used in knees in young people. If you have someone who is 47 with knee arthritis, you can do high tibial osteotomy and by maybe 5 to 10 years. Total replacement is definitely the commonest. Acupuncture is not a surgical treatment. That's your answer here. Okay. So how do you, what is a total knee replacement? So this is essentially just a pictorial thing about total knee replacement, but let's see. So what a total knee replacement, what we actually do. So let's go to right. Let's watch the video from here. So essentially you open up in the midline, you take the skin flaps away and you take the patella away, you see, patella is on the other side. You expose the knee right in front of you, and then you bend the knee so that you can see the ends of the knee like that. Then you start shaving the cartilage. Okay, so you have to create like a socket, if you like, for the artificial joint. So we use, these are called jigs. Okay, so we measure how much cartilage we are going to take off with the bone towards the end. So we make about, we make 6 cuts in the distal femur. These are called chamfer cuts. Okay, now we've made a cut in the tibia. And now you do trials. You place a tibial trial, you place a femoral trial, you place the kneecap trial, reduce it, and then you see, and you balance the knee. If you think that the knee balance is okay, and if it's not okay, you change the components to larger diameter or a bigger size of the insert. And then once you're happy, you take everything out and you replace them by your definitive prosthesis, as we are doing here. You also put cement in, which is not shown in here, which is called the bone cement. Okay, and once, there you go. That's the cement there. All right, so that cement bonds. It's like a grout, really. That grout holds the bone end to the metal. We want to take the excess cement off because it can cause problems. It gets really, really hard. All right. So, and then you suture it back, and that's your knee replacement done. Okay. So that's as simple as that. So if you have any questions about arthritis or joint replacement surgery, about complications, etc., you can put them on your chat box now. So let me see the chat box. I'm waiting for any questions you might have on arthritis. So the question is, does a partial replacement have less complications than a total knee replacement? The answer is, to some extent, yes, because you're not opening up the entire joint. However, a partial knee replacement is a much more difficult operation to do. So the chances, so partial knee replacement is less forgiving as compared to a total knee replacement. So chances of things going wrong in the partial knee replacement, in my opinion, are much higher than a total knee replacement, unless done by a super specialist who does lots and lots of these partial replacements. So it came in vogue in the early 2000s, and then it died down a little bit, but it's coming back into fashion now. Next question is, does the cement for the knee replacement contain prophylactic antibiotics? The answer is yes, always. We always use antibiotic impregnated cement. Does the TKR need to be replaced after a number of years, or is it forever? Very good question. TKR, on an average, lasts about 15 to 20 years. That does not mean it can last less or more. Sometimes it fails in 2 years, sometimes it lasts for 30 years. But on an average, if you did a survival curve analysis on your statistics, okay, which we always do, a nicely done knee will last about 15 to 20 years, but you will have to do that after 20 years. Is any of the material porous to assist with natural bone growth? Very, very good question. Yes, there is. So we sometimes also use uncemented components, especially in hip replacement. And I use a lot of uncemented in my shoulder replacement. I'll show that to you in a minute. And what we do is we spray it with hydroxyapatite and we leave it porous. So the bone grows into the hydroxyapatite, causing mechanical interlock rather than relying on cement. So that is your uncemented implant, okay? So I'll show you, so this example here. So this is a 65-year-old female, okay? She's fit and well, and she comes to you with right shoulder pain. She's got a bit of arthritis in the spine. She's got no significant comorbidities. And I've just added here no kafta. You must be wondering, what does this mean? Essentially, the smaller muscles of the shoulder, there are 4 muscles: sits, supraspinatus, infraspinatus, teres minor, and subscapularis, okay? Sits. These are rotator cuff muscles. If they're torn, they could cause problems in the shoulder replacement, and I'll tell you why in a minute. So what do? That's our X-ray, and you can see that there's some reduction in joint space. The reduction in joint space for a shoulder is best seen on axial images. Can you see this? On your left. Hello. Someone wants to say something? No? Okay. On the left, you can see the reduction joint space, okay, but on this axial image, you can see that's your glenoid. That's the humeral head, and the joint space is completely gone. Classic subchondral sclerosis, loss of joint space, osteophytes, subchondral cysts, classic features of osteoarthritis, okay? What do you want to do? Now, can you see this image now? I've got a CT for this patient. Why? Because I want to see how much bone I have in the glenoid. This V here, this is called the glenoid vault. I want to see how much bone this patient has, okay? Because if they haven't got much bone, I will do a different type of shoulder replacement, okay? So in this patient, I did which is called a normal total shoulder replacement, which is conventional, okay? So I used a plastic socket with cement here. You can see some cement there. Plastic socket, that's why you can't see the plastic here. I used a metal head, and I used an uncemented stem here. See, there's no cement. Can you see any cement here? There's no cement. So the bonding of the bone to this is through interlocks when the bone grows into the hydroxyapatite coating on this implant. Okay, another case, shoulder arthritis. You can see loss of joint space. You can see massive osteophyte here. Can you see that? Ooh, this must really hurt. Okay, and that's a poor view. See, on this one, I'm measuring again. See, this is what I'm measuring. I'm measuring, this is the line. This is where I want the glenoid, but it is actually, it's sloping backwards. So to get the biomechanics right, I have to ream a bit in the front. Otherwise, the shoulder will fail very quickly. So in this case, I chose to do a short stem. This is just to show you what different types of implants we can use. They're not always long stems. This is a short stem. Glenoid socket is plastic and cement. This is a short stem. Because you see different types of, implants you can see in, this is a short stem. And then different types of glenoids as well, plastic and metal backed. And then you have nowadays, can you see that posterior augment there? So different types. This is all for the posterior wear. Okay, so that is arthritis. We are going to move on to soft tissue pain now. We can breathe for about a minute before we start soft tissue pain. If there's any question on arthritis, okay, tell me now, and I can wrap up the arthritis and move on to the soft tissue pain. Okay, no questions. Brilliant. Let's move on to the soft tissue pain. So essentially, soft tissue pain is commonly caused by all of the following except trauma, of course, commonest cause of soft tissue pain, isn't it? You're walking, you twist your knee or your ankle and you get sprained. That's pain, soft tissue pain. Non-trauma, yes. You wake up one morning with painful, I don't know, shoulder, you know, or if you're doing repetitive work, which is, well, you could say that's trauma, but basically without any trauma you can get pain, and that condition can be called tendonitis. Bursitis, yes, bursas can get inflamed, particularly in the shoulder, elbow. Tenosynovitis, yes, the lining of the tendons can get inflamed without any rhyme or reason. Compression neuropathy, yep. So nerves going down your legs, down your arms can get compressed in certain areas, which can cause pain and tingling and numbness. That's the cause of soft tissue pain. Calcific tendonitis, yes. The calcium tends to deposit, particularly in the shoulder, and that can cause inflammation and pain. Soft tissue scarring and inflammation, yes. Frozen shoulder, for example, yeah. The shoulder capsule scars up, and that can cause pain. So that's soft tissue pain. Arthritis, so that's your answer. Arthritis is not soft tissue pain, that is bone pain, okay? Briefly about soft tissue pain, common conditions. So there are, realistically, if I'm honest, if you look at the number of cases which come to a GP, soft tissue pain cases, 90% of them are upper limb, shoulder, elbow, wrist, and hand, 90%. Very few lower limb cases of soft tissue pain. But a big part is back pain. Now, back pain is not soft tissue alone. Back pain is a mixture. Okay, that's another topic for another day for us. But anyway, so this 51-year-old builder complains of shoulder pain, 3 months duration, no rest pain, no night pain, no history of injury. The pain gets worse when he reaches out for objects. The pain is along the upper arm and tip of the shoulder. It gives you no history of past, any problems with the shoulder or anything. Family history is good, everything is all right. So clinically, he's got no muscle wasting. He's got full range of movement, but he has a painful arc. Aha. So I'll introduce a new term to you. Yeah, painful arc. Look at the man on your screen. It's interesting. When the shoulder is at rest, there's no pain. When they move it a few more degrees on the side, there's no pain. And then suddenly they get pain. This pain gets worse, and suddenly they say, pain's gone. So this arc of movement in which the shoulder hurts is called the painful arc. This is almost diagnostic of impingement or bursitis. Okay, so this guy, until proven otherwise, has bursitis or impingement. Impingement is what you see. Bursitis is what's going on inside. All right. Other examination has got good cuff power. That means his cuff is not torn. Biceps is not tender. Why? Because that could be cause of pain. ACJ not tender. What's ACJ? Acromioclavicular joint, end of the collarbone. Okay. Investigations. I don't think we need any investigations here. Okay. Apart from you would possibly get an X-ray to rule out anything else. I do X-rays just to convince the patient, really. With that sort of history, you would not need an investigation, to be honest. But yes, you might need an ultrasound scan to make sure that the cuff is not torn. So in this case, the diagnosis could be any of the following, to be honest, but the most common diagnosis here would be the last two. Frozen shoulder, no, because he had good range of movement. Shoulder arthritis, no, because the range of movement was good. Referred pain from neck, no, because neck pain referral has a different pattern. Pain starts from the neck, comes to the shoulder, can come down to the elbow. Bicipital tendonitis, no, because that pain is in the front. Subacromial bursitis, yes, more than likely. Rotator cuff tendinopathy, yes, more than likely. both of them. It could be any of the two. They often coexist, okay? So it could be either of the two. So this is the rotator cuff. From the front, from the back. These four muscles, they come from the shoulder blade, insert on the top of the arm bone. They help move the arm. And they can often get inflamed towards where they insert. And that's called rotator cuff tendinopathy, all right? And where they insert, they have a sac overlying them. And that sac is called subacromial bursa. Can you see on here? And that subacromial bursa, if that gets inflamed without any underlying inflammation, can also mimic the symptoms of rotator cuff tendinopathy. And when you move the arm, see, when you rest it, the bursa is not causing any trouble. The minute you do abduction, and you see when you do abduction, that's where it impinges here, and that's why it's called impingement. Once you go beyond certain level, the entire bursa disappears underneath here. That's why there's no pain. That's the logical explanation of the painful arc. Other bursitis seen in the body, shoulder we have just talked about. Elbow, this is called olecranon bursitis, a difficult beast to treat. Treatment largely is conservative. Like in shoulder bursitis, treatment is largely conservative, but very often I go inside with a camera and a shaver, and I chew that bursa away and shave a bit of bone, and that helps. That's called subacromial decompression. Elbow bursa, try and stay away from elbow bursitis. Treat them conservatively, mainly with advice reassurance, okay? If you try and go in and excise the bursa, it always comes back and gets infected. Hip bursitis, trochanteric bursitis is particularly common. The pain is on the trochanteric bursa right towards the outside of the hip. Runners get it, especially the bank runners, okay? And then the knee bursa. So the treatment of bursitis is generally it is conservative. There's a question from Anissa. How do you tell the difference if cause of pain is in rotator cuff tear or tendinopathy? Very good question. The answer is it depends on the experience, but if the pain is in the same position, all right, whether it's tear or tendinopathy. In tendinopathy, the tendon is just inflamed. In tear, it's obviously torn. You expect that in a condition where the cuff is torn, there will be weakness. So classically, they will not be able to lift their shoulder up. That's classic. But often the body compensates so well that a lot of people with even cuff tears have full range of movement and very good strength. And that's where you get caught out. And that is why every patient who presents with shoulder pain, where you are suspecting rotator cuff tendinopathy, you are much better off getting an ultrasound scan. So that is the only gold standard way of telling whether the pain is because of tear or tendinopathy. So you do an ultrasound scan. Okay. Right. Moving on is treatment of bursitis is all except analgesia, no brainer. Yes. Physiotherapy. Yes. Why though? Why physiotherapy? It's very easy to say, physiotherapy. The answer is, and I used to think about this, I said, why do we do physio? We just say, is it just to get rid of the patient that we say physiotherapy? Physiotherapy, if done properly, is an excellent way of treating a lot of musculoskeletal conditions, okay? So physiotherapy essentially aligns the various muscle groups in whichever part of the body. If you're talking about the shoulder, the reason we get bursitis and impingement in shoulder is because of bad posture of the shoulder blade muscles. With physiotherapy, you get the posture right, and then the muscles fire the way they should. And that's why physiotherapy helps. Injections help in bursitis, absolutely. Steroids help a lot, temporary, 3 to 6 months, but they help. Pain clinic interventions, a lot of people require like nerve blocks, okay, acupuncture, acupressure, long-term pain treatment such as gabapentin, pregabalin, amitriptyline, these kind of drugs to help them. Okay, that's why pain clinic interventions are important. Lifestyle modifications are important. Don't do that activity which is causing you pain, not a lot, repetitive, okay? Surgical excision of bursa, as I explained before, is a very good treatment. Joint replacement, no, that's a bit of an overkill, not for bursitis. I've never replaced a joint because of bursitis, and it shouldn't be replaced. Okay, so that's your answer. Right, what is the commonest cause of swelling in the wrist? Tendon rupture, tenosynovitis, gout, septic arthritis, or is it the ganglion? You know it, don't you? Yeah, it's the ganglion, right? And that too in the back. So tell me some facts about ganglions, true or false. That'll cover your ganglions. Is it the commonest soft tissue tumor of the hand? You've just said yes, so that's true. Are they mostly seen on the back part, dorsal aspect of the wrist? I just told you, yes, that's true. Ganglions are cysts filled with mucinous jelly-like fluid. True. Never painful. What do you think? False. They're often painful. They're not meant to, but they are. Some resolve spontaneously. Absolutely correct. Bible treatment has high recurrence rate. What is Bible treatment? Great treatment. You have a little lump here on the back of your wrist. You take a book, heavy as Bible, and bang it, bam. Okay? The minute you bang it, the ganglion bursts inside and it goes away. I've done it lots, okay? But it comes back in more than 50% cases. So it's not good treatment, really. Ganglion can recur despite surgical excision. The answer is yes. Very important for you to know that. That once you go in and take the ganglion off, it doesn't mean that it'll not come back. Okay? It may come back. And why? So you will think, hang on a minute, I just went in, took that ganglion out, it still come back. Why? Answer is, you did not excise the root of the ganglion. The ganglion, which is mostly on the dorsum of the wrist, comes from inside the wrist. So when you excise the ganglion, you just take the roof off. You don't go all the way inside the wrist joint, otherwise you'll destroy the wrist, right? That's why it comes back, because the root's still there. And that's why arthroscopic resection of ganglion is gaining popularity. Why? Because we go inside the wrist through a little camera, 2.5 mil camera. We go inside, you find the stalk of the ganglion, snip it, and excise all of it. Okay? Guess what? Even then it can come back. Anyway, that's ganglion. Okay, that's your ganglion. Typical, that's a lovely way of showing how so that will explain to you. So what you see on the top is just the tip of the iceberg, okay? Most of it is inside here. Okay, so that's how you do the aspiration. This is how it looks when you open it surgically. Okay, this is ironically a volar wrist ganglion. So it looks like a pearl. Okay, it's usually size of a I would say a grape, usually size of a grape. The minute you puncture this, jelly-like, gel-like, you know the hair gel we use? Yeah, the hair gel, that's the kind of stuff which comes out. So the idea is I always try and excise in total because I want to reduce the rate of recurrence. But once you puncture it and the jelly comes out, the margins get very blurred and you don't know what you're excising. So that's why you have to be very careful. And what is right next here? Next, you know the forceps? Right next to here, this forceps is your radial artery. Okay, so you've got to be very, very careful when you're taking these ganglions out. What is a mucinous cyst? That's a googly. Haha. True or false? Mucinous cyst is found in mucous membrane. I don't know, true or false, you tell me. Seen in mouth. It's a ganglion located in fingertips. It's another name for sebaceous cyst. I'll show you the next picture and then we will decide what was true or false. That is a mucinous cyst. See that? Let's go back. It's found in mucous membranes, totally wrong. It's not. Seen in mouth? No, it's not. It's a ganglion located in the fingertips. It's not another name for sebaceous cyst, okay? So these are mucinous cysts. These are ganglions located in on the tips of the fingers here. You see that? And they come from this distal interphalangeal joint because of arthritis. The treatment is not excising the mucinous cyst. The treatment is fusing this joint. You've got to treat the joint, not that swelling. Okay, try and excise this swelling, you will infect it and you will end up in an amputation. Right, 70-year-old with creaky locking finger, unable to unlock himself. What do you think that is? Arthritis, trigger finger, Dupuytren's contracture, gout, tendon rupture. So why would arthritis cause a locking finger? It shouldn't, should it? Trigger finger. That might sound familiar to you. Dupuytren's contracture. That's a permanently curved finger. Okay, there's no question of clicking or locking here. Gout, nothing to do with this. Tendon rupture, you won't be able to move your finger if the tendon is ruptured. So the obvious answer here is trigger finger. Okay, so for those of you who don't know what trigger finger is, essentially the tendons which supply our fingers. I've got another better diagram actually. This might explain some of it. So the tendons which go into the fingers, okay, these tendons, they have a lining around them that's called the synovial sheath or the tendon sheath, okay? And the tendon sheath essentially, to stop the tendon jumping over, you've got these, what we call as the pulleys, okay? They give mechanical advantage. So they are cruciate pulleys and annular pulleys, okay? And if the lining of the tendon, which I told you is a synovial lining, that's in red, if that gets inflamed, then you can get what is called as triggering. When you bend the finger, you'll see in a minute, when you bend the finger, the swelling comes there and you can't release it now because it acts like a valve and the finger gets locked there, okay? So that essentially is trigger finger. All right, I might be able to show you here. Look at this. So this is the best treatment for trigger finger is an injection. Okay, I'll show you this.
Okay. So we're demonstrating the technique of injecting the trigger finger. The triggering is in the middle finger there. Yeah, goes straight, gets stuck there. Yep, unlocks, and you can feel the nodule right there.
Can you hear the commentary?
So the A1 pulley is around in this area, just distal to the palmar crease, and it is in line with the distal palmar crease, and injection is around in this area. So it's that long. You can inject there, not there though. So in this area. And so I've got Kenalog and Marcaine. I've got about 1.2 mils, so that is Marcaine. So you go straight in. Sorry about that sharp scratch, well done. And it's gone in. And we're going into the sheath now. And the sheath, I've felt the pop. That's going in, well done.
It's quite a painful injection,
well done again, very good.
Should have recorded his face as well.
Well done. And we place elastoplast and it's all done. Thank you.
So in most of these cases, the steroid really relieves the pain and the inflammation, and that's when the triggering gets resolved. If it doesn't, then you go in and you make a cut along here and you find the A1 pulley and you just release the A1 pulley. It's a 5-minute operation done under local anesthetic that helps, okay? But you always inject the trigger finger in the first instance. Next question, it's rather long. I'll give you some time to read it. So essentially you have a 40-year-old diabetic female patient who presents with pins and needles, tingling in her thumb, index finger, and middle finger. whenever you hear that, the first thing which should come to your mind is, oh, are we talking about carpal tunnel syndrome here? So your answer is none of the above. I'm so sorry to trick you. Okay, so it's not cervical nerves, it's not brachial plexus, it's not ulnar nerve, it's not radial nerve. Its answer is none of the above. Okay, answer is this is most likely to be the median nerve which is causing the compression. Okay, so give me some true and false answers about carpal tunnel. Is it because of the pressure on the median nerve of the wrist? We have just said yes, haven't we? So carpal tunnel syndrome causes tingling, numbness, pain in the little and ring finger of the hand. What's the answer? No. Why? Because that is caused by compression on the ulnar nerve, okay, not on the median nerve. Clinical test of Phelan's is often helpful in diagnosis. Yes, it is. Nerve conduction test is helpful in diagnosis. Answer is yes. Simple wrist splints can help symptoms relief. Answer is very yes, very much so. Surgical treatment of CTS is nerve decompression. Answer is absolutely true. Surgical treatment of carpal tunnel can be complicated by infection of CRPS. And that is absolutely true. What is CRPS? CRPS is complex regional pain syndrome. Okay, so essentially, another question, is Tinel sign positive in ulnar nerve decompression, in ulnar nerve compression? Okay, answer is yes. Let's talk about what is Tinel sign. So now nerve, consider nerve like a live wire, okay? And this wire, if this being compressed anywhere, okay, let's say you're talking about ulnar nerve. Ulnar nerve starts from the neck, goes in the axilla, goes, you know, in the arm, in the underneath the elbow, comes to the wrist, and then goes to the little finger, ring finger, and it also supplies other bits and pieces, okay? Anywhere along this nerve, if there's any compression or any damage to the nerve, the body will try and repair itself. When it repairs itself, it becomes irritable. And when you tap on it, it gives you a shock. And that's called a Tinel's sign. So Tinel's sign is seen, is a sign of nerve irritability, irrespective of which nerve you're talking about. It could be median nerve, Tinel's sign at the wrist, okay, ulnar nerve, Tinel's sign in the Guillaume's canal, or on the cubital tunnel, or Tinel's sign is classically used to see whether the nerves are recovering or not when they cut. For example, if someone has a machete knife injury, okay, to the forearm, and you repaired the nerve, you repaired the ulnar nerve, but to see whether the nerve is regenerating or not, you see Tinel's sign. Advancing Tinel's sign. So today, on day 10 of the nerve repair, the Tinel sign was just under the elbow. Then it came distally, more distally, more distally. That tells me it's an advancing Tinel sign, sign of nerve regeneration. Okay, that's Tinel sign. So this is the distribution of median nerve, which you all might know. If you don't, then this is 3.5 fingers. That means thumb, index, middle, and your ring finger. If you have a patient who has numbness, tingling in the little finger and the ring finger inside, they almost certainly do not have carpal tunnel, unless they are very unfortunate and the median nerve and ulnar nerve compression coexists, which is not that common in my experience. That's your Tinel sign, okay? You strike there and you get pins and needles, shock, electric shock. That's for carpal tunnel. That's your Phelan's test. Essentially what you're doing is you ask the patient to keep the hand in that position for about, I usually ask them to keep that for about 45 seconds till I do some writing. And then the idea is that with this maneuver, you're pressing on the median nerve. And within 40 seconds, they tell you they're getting pins and needles in the distribution of median nerve, and that's a Phelan's test positive. If you are in doubt, particularly in the young people, you do a nerve conduction test. What is a nerve conduction test? Essentially, you pass current in the arm, and then you check. If you pass current in the arm, you see whether the muscles are firing or not. That's the motor conduction. You fire a current in the palm here, then note whether there is a stimulus recorded in the elbow. That's the sensory conduction. And based on that, you provide what's called as a conduction velocity, okay? And if the conduction velocity is slow, you can say there's compression across the elbow or across the wrist. That's how the nerve conduction tests work. Treatment is usually, you want to, once again, inject the carpal tunnel to calm the inflammation down. Often it's because of tenosynovitis of the flexor tendons, okay? And you do the injection, and so
we are demonstrating the technique of injecting steroid into the carpal tunnel. So in this wrist and hand, these black marks, they indicate where the carpal tunnel actually is, and the median nerve runs underneath that carpal tunnel. And if you do that for me, sir, just little finger and thumb, and up like that, like this. Yeah, so both of them together. And that denotes the palmaris longus tendon. And when you're injecting the carpal tunnel, you want to be injecting at the base of the carpal tunnel, ulnar to that tendon around here. Okay, you can relax now, thank you. So what I have here is a blue needle. I've got 1 mil of 0.25% marking, and I've got 40 milligrams of Kenalog. So I will be entering here, sharp scratcher, and my aim is to get underneath the carpal tunnel, about there. Okay, so you see half of my needle is in. I should be around the carpal tunnel. I withdraw that and inject.
Sorry about
this way. You can't go wrong.
It's fault of the person holding the camera.
That's all done. We can stop. Thank you.
Okay, so these injections are quite successful, but they're not the cure. You give them if the patient is unwilling for surgery, or they want to temporize the symptoms, or if you're in doubt, if you don't know whether this carpal tunnel, give them the injection. If they get better, you got the diagnosis. Next time they come in, you offer them surgery.
So
this is what you do in surgery. You open it up. This incision is rather dramatic. You don't make such a big incision. You just make a tiny incision. You take the transverse carpal ligament off under local anesthetic. Takes you about 6 minutes, and the job's done. Okay, it's one of the most satisfying operations you'll ever do in your life. Okay, it's very simple to learn. Ulnar nerve now. All statements are true except ulnar nerve compression in elbow is called cubital tunnel syndrome. Answer is yes. Supplies sensation to the little and ring finger of the hand. We've established that, so answer yes. Nerve conduction tests are not helpful in this particular condition. Why? Nerve conduction test is meant to help any nerve in the body, really, any peripheral nerve for that matter. So why not ulnar nerve? So that statement is false. Tinel sign is often positive. Well, if the nerve is compressed, then yes, it is often positive. So answer is true. Froment sign indicates involvement of ulnar nerve. Right. I'm sorry. I'm just throwing in some complicated things for you towards you. Like this is a real googly. Okay. So this curveball. The answer is yes. What is Froment sign? We will have a little think. And so this is cubital tunnel. Okay. That yellow is your ulnar nerve going underneath the inside of the elbow through this cubital tunnel. This is quite normal. But when you bend your elbow, like holding mobile phone for about an hour or so, this nerve gets really stretched, and you might get pins and needles in your little finger and your ring finger. This is because of the ulnar nerve, okay? And this is what patients come and tell you. And they don't have to bend their elbow for that. Sometimes the nerves just compress there, cause unknown, okay? So you can see more clearly here. That's the cubital tunnel. Look at that. So you ask the patient to hold a piece of paper, okay? And normally they hold a piece of paper between the thumb and the base of the index finger quite nicely, because the muscle which is doing this job is the adductor. Adduction. Adduction is inside towards the body, not abduction outside. Adduction. Adduction pollicis. Adductor pollicis. Okay. Adductor. Adduction pollicis thumb. Adductor pollicis. So adductor pollicis is doing that function. And adductor pollicis is supplied by the ulnar nerve. If your ulnar nerve is not working, to hold that paper, person tries to hold it by flexing the thumb using another muscle, which is called the flexor pollicis longus, okay? And that is called the Fromen's sign. This is diagnostic of ulnar nerve involvement. Having said that, you only get this if the condition is far advanced. You want to catch the condition early on when only the sensory bit has gone. Otherwise, what will happen? You will leave it too late and the nerve function will never return. Right, next condition. 36-year-old supermarket checkout worker presents with pain on radial aspect of the wrist. She works in Tesco's, and she comes to you and says, well, the base of my thumb, this area of the wrist hurts a lot. I work at the checkout and I do that every day. I think it's a repetitive strain injury. And you think, she just wants some time off work. Is it a trigger thumb? Is it trigger finger? Trigger thumb, what will happen to trigger thumb? Same what we saw before, right? It locks, but she's not giving that description. Trigger finger, no. Arthritis of the wrist, possibly, but not really. That's not the site where the arthritis of the wrist will be painful. It will be more dorsal along the joint line. Scaphoid fracture, well, there's no history of injury here. You don't get scaphoid fractures by spontaneous, without trauma. Answer is, they have this complicated condition, Decurvens tenosynovitis, simply because a chap called Mr. Decurvens, a chap who used to live in Paris, described this condition several years ago, and it still goes by his name, Decurvens tenosynovitis. It is essentially the swelling and irritation of the tendon in the base of the thumb. So the back of your wrist, okay, the back of your wrist, you can all have a look at the back of your wrist. You have, so Decurvens tenosynovitis is the inflammation of the tendon there. Okay, can you see on this? So if you look at your bases of your thumb, all of you, you will see extensor pollicis longus tendon, which is the most prominent tendon, and you'll then feel the anatomical snuff box, and the tendon underneath the anatomical snuff box is the tendon of extensor pollicis brevis and abductor pollicis. Okay, so if you look at this diagram, can you see the back of the wrist has got 6 compartments. 6 compartments. These are just fascial compartments. Compartment number 1 is what I'm talking about. Extensor pollicis brevis and abductor pollicis longus. Okay, these tendons, they get inflamed and they cause pain there. Okay, so essentially, you inject the area and they get better. Okay, so
yep. So we are demonstrating the technique of injecting Decurvens tenosynovitis, and so the test for Decurvens tenosynovitis is a Finkelstein's test, and as soon as you do a bit of, see, that's painful, I'm so sorry. So what we're injecting is the Decurvens common sheath, which is around here. That's the radial styloid outline. That's extensor pollicis longus tendon. And what I have here is marking up to 3 mils. That's 0.5%. And I've got 1 mil of Kenalog, which is 40 milligrams. So what we'll do is we'll clean the skin. I've already cleaned the skin once, and I'm palpating over the radial styloid. Clean the skin again. And the important bit is you keep the wrist towards the edge so they can move slightly down. Okay, and you want to inject in this area, sharp scratch. Thank you. And you're going down there, almost on the top of the tendon, so that needle is around here. That's where you want to inject. You aspirate and you keep injecting. Okay. And then you come out. Thank you very much.
So very important is to not inject into the tendon. So how will you know? Well, if you're injecting into tendon, you will feel the pressure, won't you? That's why it's important that you do not inject into the tendon.
Yep.
They usually get better. If they get better, but then they come back again, you know, then the idea is then you've got to release the sheath. Okay, so this I'm just showing after I've released the sheath, the tendons are now free. I should have taken a video, but this is it. Okay. What about this condition now? What is the most likely hand condition in this picture here? Maggie Thatcher. Trigger finger. You can't tell unless you ask her to move. She's dead now. Tendon rupture. No, difficult. Rheumatoid arthritis. Fingers look straight, don't they? Burn. Dupuytren's contracture. Yep, that is the answer. Dupuytren's contracture. What is it? These are different grades of Dupuytren's contracture. So what is a Dupuytren's contracture? Once again, a French surgeon described this condition. Essentially, it is scar formation of the tissue underneath the skin. As simple as that, okay? Scar formation of tissues underneath the skin. And it generally curves the finger into the palm, and it reaches a stage where then, you know, you can't straighten it at all. That is Dupuytren's contracture. Unfortunately, it is very, very common in the Caucasian population, especially of the Scandinavian descent. So something to do with the Vikings genes. Apart from that, there are no other associations really. Okay, so, and this is what you do. You ask the patient to keep the hand flat on the table. If they can't, we call it the Houston's tabletop test, and they can't, they probably have some sort of contracture in the hand. That could be because of Dupuytren's disease, okay? So up until recently, there was no real conservative treatment, if you like, for this condition. But now we are lucky that we've got this new injection of collagenase, okay? Collagenase. Collagenase is an enzyme which will dissolve the scar tissue. So you inject where the scar tissue is, and then you break that adhesion in the clinic. So you inject them today, bring them back tomorrow, and you just manually straighten the finger and you feel it breaks, okay? The trouble is it can come back, recurrence. Plus, when you're injecting, you don't know whether you're injecting the tendon or the scar tissue or the veins, arteries, and nerves. So you could damage any of the other structures as well. That's why this treatment is not very popular. Unfortunately, the CCG, or the people who have the money for the NHS, haven't improved this for use in NHS, but it's done quite commonly privately. What is a definitive treatment? And definitive treatment essentially is surgery, really. You go in and take the diseased area out. That's called fasciectomy. Sometimes it's quite bad. You take the skin out, and you have to do skin grafting. The recurrence is really common. Recurrence in the sense, if you lived another 20 years after surgery, it's definitely going to come back. So recurrence is 100%. There's a risk to the nerves which supply the digit, which is very important to mention to the patient, extremely important. If you're consenting a patient for this surgery, and if you do not write on your consent form that I've explained that there's a risk to injury to the digital nerves, then you're being negligent, okay? After surgery, it takes a while for the hand to resolve, and sometimes you have to do amputation because they present quite late. This case, for example, it's not too bad, but you know, he's got contracture of the ring finger mainly, and then the little finger. Okay, we do this typical zigzag Brunner's incision. You go inside, and he's fine in 6 months' time. So that's kind of result you can expect, really. What about this condition? It's bent after a game of basketball. Diagnosis. mallet finger, dislocated proximal interphalangeal joint, flexor tendon rupture, swan neck deformity due to RA. The answer is, what's the answer? So it's a mallet finger. What happens is the extensor tendon in the back of the joint can get disrupted by quick flexion. So the basketball hits the tip, quickly flexes it, and the tendon ruptures. Okay, that's how it ruptures. Different grades. You can sometimes take the piece of bone away, which is called a bony mallet, and the treatment then becomes slightly tricky. Most of them get better with this simple splint. You apply that splint for about 2 months, but they shouldn't remove the splint for 2 months. That's what that logo there, keep calm for 8 weeks. Okay, they can't take it off. Sometimes it's too bad, too late, or bony, then you fix it with KYs to keep the finger straight for about 2 months. Okay. Spot diagnosis, guys. Spot diagnosis. Those who said rheumatoid arthritis, they get a point. Spot diagnosis. Okay. What about this spot diagnosis? Slightly different than rheumatoid. Okay. Answer is osteoarthritis. Typical of osteoarthritis. Okay. The nodes you see, the abandoned nodes. Okay. So these are some of the statements regarding rheumatoid and osteoarthritis. I wanted you to answer true or false. RA can be controlled by drugs alone. Answer is, it's true actually. It's been a game changer, these new drugs. And we see so little of RA deformity in our clinics now because drugs have been wonderful, absolutely wonderful. Raised RF is diagnostic of RA. Raised RF is rheumatoid factor, is diagnostic of RA. Answer is no. That's very important for you to learn early on in your careers, that raised rheumatoid factor is not diagnostic of rheumatoid arthritis. It's not that sensitive, okay? Disease-modifying drugs have been very successful in treating RA. We've established that, that's true. Both RA and OA demonstrate joint space narrowing on X-rays. What do you think? Yeah? In both, you get damage of cartilage. So in both, you expect joint space narrowing, right? Okay. X-ray characteristic of RA is juxta-articular osteopenia and erosions. Yes, because we've covered that in the previous MCQ. And X-ray characteristic of OA is subchondral sclerosis and osteophytes. We have covered that as well. That's true. Both may require joint replacement surgery. Absolutely true. So all are true. What about this? What do you think is diagnosis? 75-year-old presents with painful thumb. This is an extremely common presentation in my clinic. Very, very common. They come with painful base of thumb, okay, and they've got this X-ray. You can see the first metacarpal. You can see the carpal bone here. You can see all the carpal bones, okay? Scaphoid, lunate, triquetral, pisiform, okay? Trapezium, trapezoid, capitate, hamate. Can you see the trapezium and this joint is so arthritic? So this is the first CMCG arthritis, okay? What you do is you just grab hold of the thumb and grind it gently, and that is diagnostic. Okay, see, grinding test on the left. Reduction of joint space, that's the answer. And the treatment is, once again, initially you just inject that joint with a steroid, and that helps. Give them a splint, painkillers. If nothing helps, you go in, you take that bone out. This is called excision arthroplasty. Okay, so let's see if we can show you the injection.
Lovely, so we are demonstrating the injection to the first carpal metacarpal joint. This injection is done for arthritis at the base of the thumb. So the markings show this is the first metacarpal base. That's the radial styloid. So the injection has to go into the first CMCJ, which is there. So you want to clean the skin. And you want to be able to go into that gap in the metacarpal and trapezium. What I have here is a blue needle, 1 ml of 0.5% carocaine, and 40 milligrams of triamcinolone, which is Kenalog. So you want to stretch the joint, and at an angle there, you enter sharp scratch. Well done. And you hit the bone when you go in there. And that is a trapezium. You withdraw and you inject. Well done. Inject. Well done. And that'll go nowhere but the joint itself. And put a sticky plaster. And you're done. Thank you.
So this is quite useful, this technique, okay?
Lovely.
And if this does not work, essentially you go in and you take the bone out, or you can replace the trapezium. That's become fashion, that's been quite successful, or you fuse it. Okay, now we are at 6:28. Do you guys, are you still willing to do a bit more? Do you want me to stop now? Because next is limping child. Let me know. It's been an hour and a half, so if you're tired, we can do it some other time. Okay, I've got one more. Continue, please. My goodness, I'm amazed at your enthusiasm, honestly. Carry on, please. Okay. Okay, someone says break. So, okay, I'll tell you what. Let's, yes, you will get the PowerPoint. It's been recorded, I think. And one person says break, everyone else says please going. So two people say break. Okay, I'll tell you what, let's break for 2 minutes, okay? I'll get a glass of water. You guys get whatever you want, and then we continue, all right? Okay, I'll be back in 2 minutes.
Your mouth still remember the taste of my love? Or will your eyes still smile from your cheeks? Darling, I will be loving you till we're 70. And baby, my heart could still fall as hard at 23. Thinking about how people fall in love in mysterious ways. Maybe just the touch of a hand. Well, me, I fall in love with you every single day. And I just wanna tell you I am. So honey, now take me into your loving arms. Kiss me under the light of 1,000 stars. Place your head on my beating heart. I'm thinking out loud. Maybe we found love right where we are. When my hair's all but gone and my memory fades, and the crowds don't remember my name, when my hands don't play the strings the same way, I know you will still love me the same. 'Cause honey, your soul could never grow old, it's evergreen. smiles forever in.
Right. Okay. Okay, are you guys all ready to go? Just give me a few yeses so I can start again. Lovely. Thanks a lot, guys. Okay, brilliant. So, cheers. So you got a 2-year-old who presents to the ED. By the way, ED is American, but it's becoming very, very British now. And so ED is a new A&E term. So ED is what you got to remember. By the time you guys qualify, it'll be all ED, emergency department, okay? The 2-year-old presents to ED with painful left hip and a limp, okay? How do you know the 2-year-old has a painful hip? Because mum tells you, okay? Because she says that the mother, father, the parents know. Now I've made things quite simple and easy here to begin with, and the ED doctor was very good. They did some bloods, CRP of 2. What is CRP? What is CRP? What is white cell count? I don't know if you guys know all these in detail, but I'm sure you know white cell count. So white cell count is essentially the count of the white cells in the blood. Normally it's 4,000 to 10,000. Okay, if it's more than 10,000, that means there's an acute inflammatory process in the body somewhere. CRP is the C-reactive protein. It's an acute phase reactant. So it is much, much more sensitive than white cell count. Okay, another acute phase reactant is, I don't want to confuse you, but interleukins, okay? But you can measure them, but don't worry about it. Don't worry about remembering that. Inflammatory response, when you see it through the blood, can be seen in some other factors such as ESR. That's called the erythrocyte sedimentation rate. So erythrocytes, they sediment they drop down at a certain rate, which is about, it takes about maybe 10 in an hour, 10 mils in an hour, but it's more than 10 mils, 20 mils, or 30 mils an hour. It's a high ESR. That is a sign of inflammation, okay? So this 2-year-old, painful limp, they've got CRP of 2, white cell of 6. What's the most likely diagnosis? Painful left hip. DDH. If any one of you thinks DDH, write in the chat yes. I've got no yeses in the chat, great. If any of you think it's a SCFE, what is SCFE? Slipped capital femoral epiphysis, write in the chat yes. Okay, where's the chat gone? Oopsie. If anyone thinks it's Perthes, write in the chat yes. If you think it's septic arthritis of the hip, write in the chat. Where's the chat box gone? Never mind. Okay. Right, I'm having some trouble accessing my chat box for some reason. Anyway, see, this can't be DDH. Why? Because it's painful. DDH is not painful. Okay. Yes, DDH can present with limp, but it's not painful. Slipped capital femoral epiphysis. That's not the right age. When does it present? Around 10 years. Yeah. Perthes, not the right age again. Presents around after 5. Okay. After 4 really. Septic arthritis and transient synovitis. That's where your fight is. But what I gave the game away, didn't I? By saying to you CRP is 2, white cell count is 6. So you know there's no infection there. So it rules out practically septic arthritis. So the most likely diagnosis is transient synovitis of the hip. And by far the commonest cause of a limping child under the age of 3 is transient synovitis of hip. So if you are ever asked a question, commonest cause of a limping child under 3 is transient synovitis of the hip. Okay, so how do you come to diagnosis of what is the cause of the limp in the child? So very simple. These 5 things will sort you out. It's really, really simple. It's simple maths here. Age. Under the age of 3, you're looking at mainly 3 conditions: DDH, septic arthritis, and transient synovitis. Unlikely to be DDH if it's painful. That rules it out. Septic arthritis and transient synovitis, what do? You take a history. History will tell you history of runny nose, possibly transient synovitis. Even if there's no history, clinical examination is difficult because you will not gain much in clinical examination because the child's got a painful hip and the mother is probably not going to let you touch that painful hip. So you do some bloods. In DDH, the bloods will be normal. In transient synovitis, the CRP will be normal. In septic arthritis, CRP will be high. Okay, if there's any doubt, you go to radiology. What do? You do x-rays and you do ultrasound scan. Ultrasound scan, you can put a needle inside the joint if you're really in doubt, to aspirate that fluid, that joint fluid, and see it under the microscope. If there's pus cells there, lots of white cells, that is septic arthritis. If not, it's transient synovitis. Okay, we'll give you some examples. Okay, this is just a very busy chart. Okay, I'm really, really sorry. And this busy chart.
Oh, hey, Mr. Garg, you're not sharing your screen.
Oh,
you could, yeah, if you could put the PowerPoint back up, that'd be great. Cheers.
Oh, goodness me. You guys are so polite. It took. You should have told me. Oh my God. So.
Yeah, it's back up now. Thank you.
Right. I'm so sorry. I beg your pardon. So you guys, did you see that?
Yeah, I think that was the last slide we saw.
Did you see this? How to tell diagnosis of limping child? We said we go through history, age, clinical examination, bloods, and radiology. Yeah, we discussed that. And so this is a very busy slide. And essentially, and don't get too confused about this slide, okay? Let's look at the left column first. It says disease. Transient synovitis, septic arthritis. Proximal femoral osteomyelitis. It's a very rare condition, so you can delete that from your memory. Hip dysplasia is DDH. Slipped capital femoral epiphysis is what we talked about, and Perthes disease, we talked about that. MED is multiple epiphyseal dysplasia. It's a congenital condition. You should keep it in mind, okay? History, history is important, very, very important. In certain cases, for example, transient synovitis, there's not always a history of common cold. So in history in transient synovitis and septic arthritis is not very important. The only thing is they give you history of acute onset. That's what's important, okay? Hip dysplasia, they will say that they've always been like this ever since they were born, but sometimes they don't notice it. Slipped capital femoral epiphysis is great in terms of history. They might say no history of trauma. I remember this girl who presented to my clinic about after she had walked with a family for about, I don't know, 15, 20 miles around the Lake District. And they came back and she presented with knee pain, not hip pain, knee pain. Came to A&E and next day came and saw me in the clinic. And the classic is that they get hip slipped epiphysis, and they don't get the pain there. They get the pain in the knee through the obturator nerve, referred pain. When you examine the knee is absolutely fine. And if you don't know that this could be the hip, you don't x-ray the hip. And what do? You miss it. Okay, so you miss it, and then it's gone beyond damage. So it's important that you take that history and you request for appropriate x-rays. Perthes is between 4 and 8 years of age, okay? And they can have vague hip pain, but the history is that they have been having pains for a few months when they come to, they'll usually come to you around 5 years, 6 years of age. Multiple epiphyseal dysplasia, once again, it is quite typical. They are quite short, dwarf, and they might come to you quite late, but they're quite rare. So your top 5 would be transient synovitis, septic arthritis, dysplasia, SUFE, and Perthes. Fever, well, you don't see fever in any of those except for septic arthritis. That's too very rarely. I don't see fever in them, to be honest. Physical examination, once again, in transient synovitis, in all of them, they have difficulty in weight bearing. Okay. Apart from in dysplasia, if the child is walking, they can walk but with a limp. Okay, it's not painful, and they have a positive Barlow or Tulane test, which we can talk about in a minute. X-rays are usually normal in septic arthritis or transient synovitis. They'll be abnormal in, obviously, osteomyelitis. That is a delayed condition. In dysplasia, X-rays are only seen as diagnostic after a certain age. Why? Because the hip centers have simply not appeared and ossified to be seen on X-rays. I'll show that to you in a minute. Slipped capital femoral epiphysis, X-rays are the diagnostic tool for you. Okay, so you've got to do the X-rays, and the same with Perthes. Okay, in labs, only the first two, transient synovitis, septic arthritis, is important. CRP is less than 20 in transient synovitis. In septic arthritis, CRP is high. An aspiration of the joint might show you high WBC count. Okay, so another case: 11-year-old girl presents with left knee pain and hip pain to ED with no history of injury. I've kind of given that away, haven't I? But I want you to concentrate here on the X-ray. Spot the differences on both left and right. It's a left knee and a left hip. Can you see that the head of the femur here, it seems to be slipped down as compared to this one, right? This one seems to be looking up here. If you draw a line, it's looking up here. This one seems to be looking there, right? And if you see, this is the neck. If you draw a line through the neck here, it's almost passing through the edge of the head. If you draw a line here, it's miles away from the head. Okay, and that's the diagnostic line on X-rays. Okay, that's called the Klein's line. C-L-I-E-N-S, Klein's line. Okay, so this is, answer here is none of the above, because answer is slipped capital femoral epiphysis. So what happens in slipped capital femoral epiphysis? Essentially, let's go back here. So this is the epiphysis. Okay, this is epiphysis. This is the physis, and this is the metaphysis. Okay, so the slip, this is where the weakness is. That's where the weakness is. So we're going to show this is the entire physis. Okay, the physis has several zones, and different zones get affected by different diseases. It's just important for you to understand the hypertrophic zone is where the maximum growth takes place in the physis, and that's where it's the weakest, and that's where it slips from. Okay, so this is important. So in the slipped capital femoral epiphysis, when they come to you, it can be an acute slip, or they could have had slip many months ago and they come to you several months later. That's when it's called chronic. So or it could be acute and chronic. Essentially, the treatment is, as soon as they come, you've got to fix their hip, all right? And whichever position you can find the epiphysis in, and that's what it's called in situ pinning. In situ pinning means do not meddle with the head, just fix it in the position, it'll remodel. If you try and meddle with the head, you will damage the nerve and blood supply to the head, and it'll cause further avascular necrosis. Okay, that's the treatment for slipped femoral. So just going back here to slipped capital femoral epiphysis, the commonest cause of there's one thing which is associated with slipped capital femoral epiphysis is obesity. Okay, so in obesity, you see that this is common in about 10, 11 years old boys and girls. If you have any questions about slipped capital femoral epiphysis, tell me now before I move on to the next hip condition. Okay, so the main most important thing is they come with knee pain, not with the hip pain often. So do not forget to examine the hip. Okay, the hip will have restricted range of movement, and an X-ray will show you the slipped femoral epiphysis. So next case is a 7-year-old boy from a socially deprived background, and he has a limp. This is X-ray on your screen. You can see this is so different, isn't it? You can see the left hip, you can see the epiphysis, the physis, the metaphysis. That's the greater trochanter developing here. That's acetabulum. But here you see, something is not right. This head appears to be destroyed. This could be septic arthritis. This could be AVN of the femoral head. Okay. Maybe it did not develop properly. It could be DDH. It can't be a septal femoral epiphysis, right? So if you look at the head here, it's got a characteristic appearance of avascular necrosis, but also of regeneration. So there are areas where the head is dead, areas where the head is trying to live, body is trying to repair it. And that is the classic hallmark of Perthes. Okay, so in this option, in these 6 options here, Perthes is the right answer, but AVN of the femoral head is not a wrong answer. Okay, because yes, there is AVN of the femoral head. Okay, now what's also important in this history is socially deprived background. That's one association. Like in slipped capital femoral epiphysis, we discussed about obesity. In Perthes, it's socially deprived background for reasons we don't know. Okay. So Perthes essentially is idiopathic, i.e. we don't know the cause, AVN of the femoral head, okay? And it goes through phases and, you know, initial phase, interim phase, and the last phase that gets really, really worse. And essentially, going back, the treatment of Perthes is largely conservative. You try and keep the hips into a place so that the femoral head is centered into the socket, okay? And that is really important for development of the socket and of the head. And with time, the body will look after it, okay? And that is the only treatment for Perthes, really. Unless it's so bad that then you have to do a joint replacement when they are slightly older. DDH, which of the following statements are true regarding DDH? I'll let you read that. So one of the questions was, sorry, you said there were signs of regeneration. How do you recognize that? So when you look at an X-ray, the AVN looks like more like radiolucent, and regeneration looks radio-opaque. That's the main difference. So if you see areas of radiolucency, that's where the lysis or AVN is. If you see areas of regeneration, it looks more like normal bone and more sclerotic, if you like, to begin with. Okay. Now, going back to this one, most common orthopedic disorder in newborns is by far the DDH, no doubt about it. Most common in firstborn, yes. Firstborn, female, and feet first, 3 Fs here. Okay, firstborn, female, feet first is breech, okay? And older women, they say in the 40s, that's another 4 if you like. But ultrasound is a primary imaging modality from birth to 4 months is the right answer. Why? Because X-rays are not that developed. I mean, and X-ray changes are not that developed in the first 4 months, okay? Pavlik harness is mainly used for the for 2 to 3 years old in DDH child. So that is confusing, that option I've given you. What I wanted to say in that option is Pavlik harness is mainly used for children who are 2 to 3 years old. Answer is wrong. No, it's used mainly for younger children, i.e. those in the first 12 to 18 months. After 2 to 3 years, DDH, it's far too late. Pavlik harness will not do anything. Most cases require some form of surgery. Answer is no, they don't. Okay, most cases do not require surgery. So essentially, in this country now, if there's every child who's born in the hospital or otherwise undergoes a routine check by the pediatric nurse and the pediatric doctor, and they examine the child and they go through their movements and look for whether the hip is unstable or not. Okay, if they have any doubt, they get what is called an ultrasound of the hip, and that establishes the diagnosis. So this is like a national screening program for DDHs, which is currently running in this country for several years. Okay, so that's how we don't miss DDHs now in UK. We used to miss a lot of them, but we don't miss many these days. So look at that X-ray, left and right. You can clearly see on this X-ray, can't you, that the right hip is out, the left hip is in. What about this X-ray? So you draw two lines, the horizontal line through the acetabulum. This is called the Highland-Grens line, and then you draw another line outside the acetabulum. It's called the Perkins line. Femoral head should be in the inner lower inner quadrant. Can you see that here? And it is here, even on the right side, but it is smaller. That indicates possible DDH. But then, if you look at the Shenton's line here, on the left, it's broken here on the right. This is an indication of DDH. Okay, the same here. It just shows you the Highland-Grens line and the Perkins line. Okay, and this is, I don't think you will be asked about this at your stage, but this is just to know that X-rays help. Okay, and I think that concludes the session for limping child. If you have any questions regarding anything that we've discussed today, we can have a good discussion. You know, I've got plenty of time and we can go through whatever you want me to discuss. Because the next topic is quite long. It will take at least an hour, another session. So if you have any questions about the limping child, arthritis, ATLS, common conditions of the hand, shoulder, Dupuytren's contracture, decurvens, ganglion, you know, just ask me and we can go through them. Unless you're very tired and you just want to go and get a chilled drink. So right. So are we having another session for the next topic? Not today. Not today because it's close to 7 o'clock. But we can. Okay, question here. Regarding mallet finger, does the speed of trauma affect whether a fracture occurs or not? I think yes. So it is mainly to do with the force. If you suddenly bend the finger in flexion because of fall or something hitting the tip of your finger, then it can cause a bony mallet or a soft tissue mallet, really. But if the force is hard, if the force is high, then yes, you can have a bony mallet. But you know, I've had people with bony mallet after a basketball injury. I've had people with soft tissue mallet after this injury. So not always. But thank you all for joining. I'm very grateful for your engagement. It's great to see you youngsters on this forum here. And once again, thanks a lot to Jils and Tanya for organizing these sessions. You guys are doing a very good job. As I say, if you want any other topics, etc., write in the feedback and we can arrange something. Next week, I think, or this week, you have what's called as a formative exam. It's not a summative exam, so it's not counted towards your marks. We don't know what's going to happen to the lectures yet because we are still talking to the Norwich Medical School regarding what's going to happen to the lectures. So I'm preparing a base of lectures, etc., with my colleagues so that we can deliver them when you come to the secondary care. We can do that. Otherwise, I might see you on one of the lectures when we start delivering them. We're not sure when we'll do that. Okay, so if there are no further questions, I'm going to bring this session to a close. I will send the recording link like I did last time to Jils and to Tanya, and you can get it from there. Okay, so take care everyone. Bye now.